Okay, all quiet now, please. Okay, we're going to start for the super fantastic lecture here. First of all, I'd like to wish Happy Diwali to everybody and a Happy New Year to everybody as such. That's mainly a Hindu festival, but anyway, Happy Diwali, Happy New Year to everybody. I'd like to thank Lana Hugenboom for organizing this lecture and also for Utsuka Pharmaceuticals. Please give a big hand. Also to Sabahat Ismail Ji for organizing the lecture also for Utsuka Pharmaceuticals and Vijay Pharmaceuticals. Thank you very much. It gives me great pleasure and honor to introduce our super genius, super great speaker there. If I go on talking about him, it will take me more than 2 hours. So I'm going to cut short and just speak for 20 seconds. Dr. Vijay Dutta is a professor and colonel in the Indian Army, and he graduated from the University College of Medical Sciences in New Delhi. That was 30 years back. After that, he did his specialization in internal medicine, MD internal medicine, and then in pulmonology, that's respirology, from AFMC in Pune. After that, he has been with the Army the Indian Army for the last 30 years, and he had been a captain, he had been a colonel, lieutenant colonel, and all those positions. For the last 5 years, he has been working with the Indian Spinal Injuries Unit in New Delhi. He is the senior consultant and as an internal medicine specialist as well as pulmonary specialist with the internal spinal injuries and the professor of medicine there. He has done lots of volunteers work, going almost once a year or twice a year to Jammu and Kashmir to hold the medical and surgical, medical and surgical, in fact, camps there, in fact. Plus, in fact, he has traveled all over India, and as the Army captain, he has served the Indian Army for a lot of years there, and at all the capacities. Tonight, he is going to share some of his fantastic knowledge and talk about battling COVID war, physician fatigue, PTSD, and physician burnout. During this COVID which was going on, he was one of the physicians who was working day and night, not just 1 or 2 days, but he went on for 1 year, 2 years, 3 years, till the COVID is over. Well, sort of over, it's still going on right now. So he's going to he's going to show us some video as well as slides, and let us enjoy that. Dr. Vijay Dutta.
Thank you. Good evening, ladies and gentlemen. It is my proud privilege to be standing in front of all of you to present my experience of COVID-19. I'm sure all of you here in Canada also must have experienced similar experiences and similar, you can say, the challenges of the medicine which is still going on in our in the years to come, because the COVID-19 is part of our now the biological system and ecosystem. It is not going to be out as we used to think earlier when the COVID-19 came in 2019. Until today, so many variants and sub-variants have come, we do not know what is the end of it. And so many vaccines have come up and so many innovations have come up courtesy COVID-19 that it is for all us to know that what lies ahead of us still we cannot predict. Next slide. It is not going. So it basically contains my personal views while working during COVID-19 and while I was there at Delhi at Indian Spinal Injury Center. To start with, Indian Spinal Injury Center is basically a tertiary level hospital which we have. It mainly treats the spinal cord injured patient which are high cervical or maybe high thoracic cord injuries. That is the basic workload, and in addition we have people coming to us with various other medical or surgical disabilities as well. But during COVID times, because of national pandemic, the whole of the hospital, all 200 beds were converted into the COVID. So it was primarily a COVID center which we were treating. So we had triage facility, we had ICU, HDU and general ward. Next. So this is just to share a video which is of course does not belong to us. It is just taken from the net. Yeah, you can play. So it shows how the ICU
India set a worldwide record nobody wants for a second day running atop the number of global daily coronavirus cases. They're shocked and ashamed at how the country's healthcare system is all but breaking. The weak and ill have spilled out onto the pavement outside, and there's no dignity in death here. The final few breaths taken by this man came after his brother had begged for oxygen for him for 6 hours. Some turned up barely able to walk, only to turn around immediately after being told they'd be better off trying elsewhere. Whilst this family brought their mother, but saw her die minutes after reaching what they hoped was help. This hospital is useless, she's shouting. But it's not isolated in its inability to cope right now. Only grief is here in abundance. Distraught relatives found no beds, little oxygen, few staff, and even less hope.
Thank you. The basic premise was that whenever we used to have casualties coming to us, it used to be any driveway of any of the fast moving, like you have McDonald's drive-through. So ambulances used to be back to back, or even the private vehicles where the patient used to be coming, put on oxygen mask or oxygen cylinders. And the moment oxygen used to be over, people used to rush and run for the oxygen as if they have a big solace for life. So people used to have a basic need as the oxygen. People used to keep oxygen cylinders at home, oxygen cylinder in their vehicles as a standby. So we had basically the facilities were overwhelmed, all the facilities, and we were unable to actually hold that many number of people, because moment person comes in a desaturated state to give high flow oxygen, and the other NIV support was the big challenge for all of us. The antibiotics, as we know, has no role. The management lies mainly with the steroids and the low molecular weight heparin. The heparin is the mainstay to prevent all complications. And if the other drugs like remdesivir and the tocilizumab or itolizumab, they are just add-on therapies, they are not the life-saving drugs. So the only thing which helped the people was steroids and the heparin all over the world. And it was the UK people who came out that not the salomedrol, the plain and simple dexamethasone, which is the cheapest of all, will save the life. That is how it came to the knowledge of people, and then it became a standard line of therapy or care. Yeah. So this is one of the X-ray. If you see, there is hardly any area of lung which is not consolidated, and this is the corresponding CT scan which shows the classical ground glass opacification right from apex to down below, and the person had to be put on ventilator. Next. So this is how the people used to be given a subacute injection of heparin, and somebody used to develop hematoma. The down below in the suprapubic region, what you see is the fungal infection, which people, because are on high doses of steroid, used to develop tinea corporis as a skin manifestation. Next. So once we are giving high doses of steroid, the other challenge was to manage their diabetic state. Those who are pre-diabetic or overtly diabetic used to have uncontrolled diabetic state. So we used to have titrate this diabetic state as it is shown in one of our patients, that the sugars are fluctuating to the tune of 300 to 271, and we have to set up an infusion pump to give insulin, not as a sliding scale but as an infusion pump, and every hourly or 2 hourly we had to adjust the insulin to titrate up to 160 to 180 level. Next. So these are the corresponding ABGs. This is how we used to tabulate. This is the investigation chart, the sodium, potassium, what you see, and the arterial blood gas analysis of the same patient. And this is on PRVC's mode of ventilation, which we have put with the tidal volume and other things which are handwritten over it. This is with the face mask with the on the left hand side. Yeah, next. So these are basically just to show that what was the tune of this spectrum of people which we were having in our respiratory ICU or HDU. Next. So similarly, this is one of the patient of cervical injured. You see the this prosthesis which has been put, the spine has been fixed. In addition, the patient developed COVID, and this is the corresponding X-ray and the CT scan over period of time. The patient gradually started improving later on. Next slide. This is how we used to be geared up in full PP. On the left hand side, it is myself with respirator on and with PP, and this is the modification which we had done to keep our pens, the gloves outer cover, we used to plaster it on our right hand side just to carry our pens along. And this is the team of doctors and the paramedics who is to accompany us for the ward rounds. Next slide. So this is how our HDU facility used to look like, and on the down below corner is the ICU where the person has been put on NIV support. The patient had CA colon. In addition, she was on end colostomy and undergoing chemo pulses when she developed COVID-19, and she was fortunate enough to survive the COVID-19 disease in spite of having ARDS. But her husband, who was hale and hearty when he came to us, he was working on laptop. He was a big time businessman and had a factory to support. In fact, he was giving instruction when he came to us in triage onto his laptop. I requested him not to do it and just to concentrate on his breathing and put on the mask, which he was reluctant to do it. Of course, that was his destiny, and over a period of 48 to 72 hours, he deteriorated so badly that we had to intubate him, put him on ventilator, and that was the end of his life. Next slide. This is one of the ICD bag which is full of serosanguinous fluid, and this is one patient for which I did bronchoscopy to take out the mucus plugs, because the bronchoscopy used to help the people where a lot of mucus plugging is there. In our experience, the early bronchoscopy helped the people to come out of the NIV supports, and it helped rather early recovery. Of course, and in addition, this bronchoalveolar lavage used to help us whether person is having some secondary infection or not. We used to subject this bronchoalveolar lavage for cultures, and accordingly all our microbiologists used to help us that what is the actual bug which we have to target and treat accordingly. Because many a time, few cases of pulmonary tuberculosis which you may not be seeing here in this part of the world, but here in our country, we have big challenge of pulmonary tuberculosis, and once you have latent tuberculosis, it becomes overt tuberculosis by giving such high doses of steroids. And we have seen people coming with TB meningitis, with disseminated tuberculosis, with COVID-19 disease per se. So that is the dilemma lies what to treat, which things to be given preference first. So obviously COVID-19, because that is killing the patient, you have to oxygenate first, then you can treat simultaneously with antitubercular therapy. Next slide. Yeah, this is one of the patient who went into renal failure. You can see we have put in the jugular line. Patient is noradrenaline infusion, and in addition, we are undertaking the dialysis for the patient. Patient used to develop all possible complication which you can think of in ICU setting. Yeah, next. So these are the host of ICU settings. Ventilator is going on, all beeps, and the patients used to be given rest by giving fentamidase infusion, but the paramedics and the doctors, there used to be so many code blues and code orange in a day that we used to be fed up of running from one corner of the hospital to another, and we used to be out of breath even. We had no time. We used to wear diapers just to relieve ourselves because there was no time even to go to washrooms. And what to talk of, because it used to be February late onset, the Delta wave came basically in late March and early May. It used to be very hot and humid. We used to sweat profusely, and our hands and body used to sweat so heavily that at least myself used to take 2 full jugs of Nimbu Pani to rehydrate myself. Otherwise, I used to feel that I am feeling groggy and I will fall totally dehydrated state. I will have heat exhaustion or heat cramp sort of thing. Next slide. So these are the few ventilator settings, and this is a repetition of the same. Next slide. Yeah, this is one interesting case what we came across. In spite of giving so much doses of heparin, person developed basically lower limb, I do not know how much variation of lower limb, that cyanosis you are able to see. This patient developed, actually this is the MR angiography which we did, and we could actually demonstrate a thrombus within like this. So that thrombus was the responsible, and we had to take this thrombus out because and basically thrombectomy we had to undertake for this patient by requesting our cardiologist colleague. Otherwise, he would have lost his limb. Next. So there were few people, because the mentation of the patient was very, very important. There were few people who used to be very, very sort of morally and psychologically very strong. Even if the person is in the ICU with NIV, whenever we used to approach him, because there is all spectrum of people, and whenever you used to approach him, how are you feeling, they used to always give us thumbs up. And that used to be because we cannot communicate. We practically have to loudly howl at the patient, how you are, to examine the patient, whether the person follows our command or does not follow our command. It was a big challenge for all of us. And how to communicate with the patient, sometimes we had to write and give the written commands, and whether they are following it or not, that was a big challenge for us also. So it was a big communication gap. So many a times you are talking to a person, whether the person has understood your question or not, that also was big challenge. Next slide. Now coming to seeing all this trauma, all healthcare workers, whether it is paramedics, doctors, everybody had a fatigue at the end of the day, because moment the shift used to change, the nurses were sort of very much hopeless that everybody who comes to ICU or HDU just deteriorates from HDU, goes to ICU, and practically whosoever goes to ICU, 90% of the time there is a death. So person giving a sort of ventilation, it used to be rarely mechanical ventilation, the person you get be relieved or could be retrieved out and could go back to HDU facility. So it was sort of death sentence practically, person coming on ventilator. So we used to feel helpless, we used to feel morally that we used to literally sit and feel dejected seeing the patient, that what we as a physician or a pulmonologist, what I am doing, I am practically giving a death sentence to the patient. Many a time in the wards, the oxygen used to finish, we used to run from pillar to post to the administration and to other people to get the oxygen, because central oxygen supply, the oxygen pressures will go down and it starts beeping. All the monitors, including every patient in the subacute ward, had their own pulse oximeter. We used to, the moment patient used to get admitted, we used to issue them a pulse oximeter, the finger held, and the patient used to monitor their own. And the moment they used to, we used to tell them, moment you are feeling difficulty of breathing, you must give an alarm to the nurse, and the nurse used to in turn put up a alarm and code orange used to budge, and we used to rush there to help the person in and out. So that is how it was a big management involved, including orthopedic surgeon, the spine surgeon, the fellows, everybody pulled in. I used to type a protocol and used to give it to them that this is the only broad outline how you should approach. The triage used to be full. Many a time we have kept so many bodies on the side room of our ICU or even in the triage. By putting a screen, we have put so many bodies because all our body boxes are full of bodies and we are unable to dispose them of on time. So that was big demoralizing, and that is how the turning point of people, depending upon individual to individual, it used to be different. So that is how this PTSD was seen in our majority of the patient, the healthcare workers who are attending to this of COVID-19 cases. So basically, as you being the mainly psychiatric by profession, I need not teach you all this. This is basically the same which you know all that. I want to pursue the next slide. The acute and chronic PTSD. I had this phenomena while I was serving in Sri Lankan operation, and I had near-death experience. So during that time, I know how important once you survive out of near-death situations. And now same thing is repeated after a gap of 30 years. So practically, I had no sleep. I could not sleep at night. I had to take sort of medications to come over that vicious cycle of, and every time you are thinking of the patient, every time the patient's attendant used to ring up, we have to remember that so many patients are there in ICU, so many people are deteriorating. We used to get WhatsApp messages, WhatsApp call, and sometime the night duty residents or ICU staff is ringing up. So every time there is no rest practically. In the morning, I used to get up at 2 a.m., write mail to administrator that what is to be done, what is our priority line of action, how to go about. So this used to take lot of stress and fatigue on our minds and brains, and your emotion used to be totally blunted, and you are like unable to sleep properly, unable to cooperate properly. But yes, you are working like a machine once you go inside the hospital. Yes, that I agree. Next. So symptoms are the recurrent intrusive distressing recollection of the event which we are facing because of, and it was so much so that it carried on for almost 3 to 4 months non-stop. And every time you are going, I used to go at 7 a.m. in the morning and used to come back only 8 p.m. Every patient I personally used to see, there was a time when there was almost to the tune of 150 patients admitted under me directly. So I was responsible for their initial documentation to all progress notes, everything, including giving instruction, and in between, of course, running from pillar to post, whosoever deteriorates, and then maintaining them, and how to do my own management of my, because being the HOD, I was responsible how to recruit people, how to carry on the team along. That was also a big job for me on my head, which was given to me. So it gives an intense psychological distress to exposure at the things which symbolizes or resembles the aspect of trauma, including the anniversaries thereof, and it leads to irritability, outburst of anger, and irritability which can progress to even a rage. Next. So how to avoidance feature the efforts to avoid activity places which was not possible here, and there is inability to recall. These are all theoretical things, but they are not possible with us while we are handling COVID-19 pandemic. Next slide. The diagnosis, as we know, has no, there are various tools which all psychiatrists have parameters to, like they have various tools where they can ask the patient that you give a tick mark or give your numbering, and then you make out that how much is the stress level person is having. So we didn't have, but we used to definitely ask our psychiatrists and clinical psychologists to help us in assessing our staff and all the patients who are under stress, because per person who is not, even if clinically the person has improved, saturations are okay, many a time in subacute wards the person used to feel that I am not going to survive. So there we used to take help of our both psychologists as well as psychiatrists, which were there on regularly on board, to help the patient out to come out of the vicious cycle. And there are many patients who are not ready to go home because they had no supply of oxygen at home. So they used to feel that oxygen is the main lifeline which will keep them going while they are in the hospital, and once they go home, unfortunately they won't have avenues or revenue to carry on with the oxygen therapy. So that is how it is very important for them not to leave a bed. I know a person whose dad was admitted on a diagonally opposite bed. Practically I had to tell this boy who was must be 16 to 18 years of age that you please vacate your bed and give it to your dad who requires high flow oxygen. This boy was reluctant. He is holding on to his mask and not willing to hand over the bed to, practically we had to lift him physically, remove him from the bed and hand over that bed to his dad. Ultimately his dad died and this boy survived, and the boy was hiding inside at the corner of the bed, and at a will, because we were in PP, so we could recognize that he is changing his beds very now and then just to prevent or prolong his stay in the hospital. That is how few subset of people used to behave like that also. So because they are afraid of, everybody is so much afraid of death, and so much of the news, the media, and everybody is creating horror, and there is so much of horror going on everybody's mindset, and so many deaths are happening in the family that everybody was afraid to get out of the hospital. Next. So what are the classical stages of burnout? Is the overcommitment, beginning of exhaustion, increasing exhaustion, and feeling burnt out. Next. So what does self-care look like for you? It should be self-compassion, reframing, gratitude and appreciation, of course humor, financial goal. I do not know how much it would have helped during that stage, and basically you have to have time for yourself. You have to have good, comfortable 6 to 8 hours sleep, which was not possible for us during this pandemic. Adequate food, timely food was again sort of these regular interval of water and food was also a big challenge for us. And aligning with your own values of the society, which our parents have taught and what we have during our medical school. Next. So the compassion fatigue, the contributory factors of helplessness, confusion, isolation, exhaustion, and feeling of overwhelmed by the work, which was of course there. Next. These are the commandments of the physician wellness, that this is all known to us or taught in the medical school. This is nothing new, but to remember it and to practice is the big, it is next to impossible. At least it is not possible for me to all carry on like what it looks like a Hippocratic oath, but to carry on correctly and in principle it is not possible, at least for me, after 36 years of medical practice. So accordingly, what Aristotle had said, that we are what we repeatedly do. This is very important. So what we have to basically look at is the brain training, that basically you have to emphasize on your breathing, because whenever there is an imbalance between parasympathetic and the sympathetic system, because the sympathetic system is the overdrive which rather kills your impetus to carry on. Because if you are overburdened by the sympathetic, you get burnt out. So there has to be equibalance of both parasympathetic and the sympathetic system of a human body, just to maintain an equibalance. So basically you have to anchor attention on the breath. The attention usually wanders, and then you notice that the attention has wandered. This is very, very important. Then notice our reaction, choosing the reaction, whether it is frustration or compassion. Then return to attention and the sensation of breathing. So basic aim is like what we are taught in pranayam, that you concentrate on your breathing and you do deep breathing and shallow breathing, and try to concentrate on your breathing and try to reduce all the inputs. Next. So this has been proven that the hippocampus and the amygdala, they are the basic centers for our brainstem, which controls our emotion, which has been proven on the MRIs. Next. So the basic thing which has helped us is the meditation. So we used to, in addition, we used to have various classes, like our psychologists, psychiatrists used to conduct webinars for us. Those people who require pharmacological help used to be not put off the roster, and they were given adequate rest and few holidays just to recuperate and to come to the subacute state of ward, not working in the ICU or HDU setting, because there so much of stress level is there. So that is how we used to manage our things. So the primary health benefits from the meditation practices appears to be general shift in the autonomic nervous system that decreases the sympathetic tone and increases the parasympathetic tone. It has been documented well that it improves the depression, it reduces the anxiety, it improves the quality of sleep, it does improve our immune function also, it improves the cortisol level, does improvement in the decision making and coping up with the stressful condition. So, and in addition, you give paying attention on purpose in the present moment, and you are non-judgmentally to the unfolding of experience movement to the moment. Next. So, at the end, may you be happy, may you be healthy, may you be free from internal and external harm, and may you experience love, joy, wonder, and just as it is. May you have ease of the day. Any questions are welcome. I have finished. I want to thank for your patient listening, and thanks all the sponsors.
Thank you very much, Dr.
Thank you.
Give us a very good insight about the COVID treatment and what really exactly happened in India, in fact, and as well as other countries as compared to what we saw here. Of course, we as clinicians, we are working outside, working in the office, not in the hospital there. We do not know the exact thing what is happening in the hospital there, but at least this gave us an insight with the video and your presentation what has exactly happened there. So thank you very much. That's really
Thank you.
good. Thank you. Any questions, please? Yes, Dr. Gul.
Looking at the impact of media
Sir.
and social media especially, looking if this had occurred 30, 40 years ago, and the impact was not so wide, the impact of disinformation, misinformation, and the anxiety created by this being repeated over and over again, would, social media is a double-edged sword. So would it have been different if social media was not that active?
Sir, I would say the social media, if like what present day scenario is, this social media has rather helped not only the clientele, it has helped the medical care givers also. Like whatever is happening in UK, whatever is happening in the Western world, like immediately the very next moment it is announced by Dr. Fauci with the President's immediate health and care advisor. So the moment it is announced in US, we used to come to know. While had it be other way around, maybe it was not possible. One, like what happened in 1819 or almost that time, when the this common cold epidemic or this, in fact, same sort of pandemic had happened and people had perished. So similarly, we had almost a gap of 100 years. The same thing has happened again, but I think the what we are not tuned, I do not know about the Western world, but especially nobody, including armed forces in India, or we didn't have infrastructure to handle such a volume of patient coming, like opening of floodgates. People are coming and only requiring oxygen, and oxygen is not there. See, that was the irony. As a doctor, I cried even in the HR that what for we are admitting patient, what for we are there. We are unable to provide steroid. I am unable to provide even low molecular weight heparin, because there is so much lobbying of the medication that people are hoarding. People are doing hoarding of the medication. That was the unfortunate part, and our so-called administrators sitting at the helm of the affair at Delhi government or maybe national government and in the hospital. So there is total system failure for good about 2.5 months. After that, definitely it got more streamlined and we were getting drugs, of course, not to that on a volume or the quantum what we required, but yes, we got the medication. But the unfortunate part is that it requires a lot of setting of drills, setting of like one should have for any epidemic or pandemic. Like I worked during swine flu pandemic. I was there in the army, so I treated around 2,000 people in base hospital Delhi Kent. I had only one fatality. But there I had the helm of the affair. I was given the boss and I was in charge. Now here people are having lockdown. It is a big challenge for the patient to come to the hospital. The mortality was happening because people were coming late. It was not that a hospital is not able to work out and we do not know how to treat a person. So that is how, because people used to think that these are the red flag signs, so might as well stay at home. So they used to delay their movements to the hospital. So in a way, the social media has helped, and on the flip side, if you see, it has done some bad things also. So basically, it was basically to walk on a basically knife edge, which the patient or the patient's attendant had to decide. Many a time patient wants to go, but the family feels that if we send our near and dear to the hospital, it is a death sentence. But it was not always. I agree that majority of patients who were coming late, obese, old, and they used to have the fatal end, no doubt about it, which was their pan word. It was not that only in India we experienced that sort of thing. Thank you.
Yes, Dr.
So it was very distressing to watch those videos and all those patients suffering. The right to life, the human basic right, so it is the responsibility of the state to provide that. So
Correct.
when they failed like this miserably, who took the ownership, responsibility, and what steps have been taken for another episode like this?
See, when the initial onslaught was there, I agree with you that all the politicians, as they are I think all over the world, they are in habit of saying that this is not my doing. The infrastructure I cannot create overnight. But definitely what they did was the legislation to acquire all private hospital, because we have government setup, we have private setup, and we had a certain hospital which was set up by the army, which was dedicatedly only working for COVID-19. They had tentage, which were fully air conditioned, and they were working, in fact, in between our international Delhi terminal and the local terminal or the domestic terminal. There was a big landscape which was lying vacant. So there, with the help of bulldozers, they had leveled it up and they opened up healthcare facilities, and various other ashrams or wherever they find a space, they had put up basic facilities like giving oxygen, like paramedic staffs were arranged, all volunteers were arranged to provide the basic help like food, steroids and heparin. We were giving, like patient is now stable, does not want to go on discharge to home, because everybody wants their spectacle, like they have only washroom at home. So even the family are spectacle of receiving their own near and dear back home. So they want a facility where they can sit together, so that they are at least 2 weeks later on only they are able to be taken into their household. Because everybody is afraid, and including their own near and dear are afraid that person has come from the hospital, so person is likely to be having infection or carrying some problem like even a fungus or some sort of resistant bug onto them, which will be sort of detrimental to the health of the society, or maybe the young kids at home and old people at home. So everybody is spectacle of receiving with open arms. So that was also a big challenge. So this is how the later on, after 2.5 months only, the administration or all the you can say the ministers and everybody realized that their role of and of course lockdown was there, so that helped in keeping the people confined to the geographical limits of the cities. So that is how also it was a big help in containment of the infection also.
Can I just add a couple of things?
Yeah.
Which I really want, I hope you can put it in your presentation in the future, is that how quickly India mobilized and opened that level of number of beds. Because I was in Chennai in September 2020, because my dad passed away. I went there, stayed there for 25 days. One
Okay.
of my close friends was also a public health physician who was in the front line of acquiring PPE for the entire state of Tamil Nadu. You wouldn't believe Chennai opened 7,500 extra beds in a matter of a month.
Yeah.
I'll tell you how difficult it is in a Western country. I see COVID as a Western system failure, whereas we don't talk about much that if you can add how many extra beds were opened by the government in your city and things like that, because people should know the might of Indian government, how it mobilized and opened the beds. It was 7,500 extra beds in Chennai city alone.
Yeah.
Here we took the Vancouver Convention Center and planned to open at 250 beds, which we never ended up opening. We paid the rent for the convention center, which
Okay.
we never materialized because we thought we were able to manage, despite the fact that all the ICU across British Columbia was full. So I know that right to life is the same for somebody here as well as anywhere in the world.
Correct.
I have to really say that there is a very big positive aspect of COVID management in India, which I think I'm pretty sure that you could include that as well, because thousands and thousands of beds were mobilized, but the size of the population, they were not able to cope up with the amount of remdesivir and oxygen, and then the role of social media influenced quite a bit to find oxygen supply and things like that. So I witnessed that firsthand in Madras, so that's why I'm talking about it. There are loads of positive things that came out of how you said your 200-bedded chest hospital was changed into a COVID unit. Another chest hospital in Chennai, which was 500 beds, for 400 beds, where extra 400 beds were created to create COVID units.
Correct.
So those kind of mobilization, I can assure you, it doesn't happen in any Western country, including America.
Okay.
So that's kind of a comparison. It makes how proud we can be about seeing India, how the largest democracy has mobilized the beds.
Correct. But the issue is like like I worked during swine flu pandemic in the army. So had it been preempted by the politicians and the administrator, basically those who are sitting at the health secretary level, if they coordinate with the doctors community, because the unfortunate part of Indian healthcare system is that we have parallel systems going. So private sector is more of profit making, while the government sector is all together. So how to unite and make them have common goals, that is a big dilemma for the state of the health. So if that is achieved and that is integrated, so it is a big force to reckon with.
Sir, I like to ask that, how long did it take for you to get over the trauma and back to normal life? And
See,
what measures you took to take it off?
See, I took medication, I took help of psychologists, including psychiatrists, to help me out to come out of that trauma.
And how long did that?
Minimum 3 months.
It takes much longer than that, to be honest with you. Once you have got PTSD, it takes minimum, not 3 months, it takes about 2 years and longer than that. The issue with physicians is it's a denial. Okay? As you know, you're a physician, I'm a physician. We are in the state of denial all the time. Okay, all the time. And therefore, even if there are some symptoms there, etc., or even moderate symptoms are there, we are still in denial. Unless until it's so severe that we are totally dysfunctional, then we come out in the picture. Otherwise, not. That's the problem.
Are you feeling normal now, sir?
Yeah.
That's how I traveled and I am able to speak here and in UK.
He gave a different talk in Nottingham in England at a conference there. He was supposed to give another talk in England also, as well as at Boston. But I guess since his talk was really fantastic, I approached Lana and I said, I think it's worthwhile to have this talk here to amongst all the physicians and psychiatrists so that we can learn something from this. And of course, the COVID was a disaster thing. In fact, like even just talking about my own family. In fact, my own cousins, I lost about 9 brothers and sisters in about 18 months, out of which 7 because of COVID itself. And they were all professionals. It's not that professionals, even physicians, pharmacists, engineers, etc. 2 of them, in fact, they came here to see Canada in 2019. And I think they met a few people down here, in fact. And a year later, exactly a year later, they had a trip upstairs, you know. It's just sad to see that, but that's what life is. That's what life is. You know. Any other questions? Yes, please go ahead.
A very simple question.
Yes.
If you don't have sleep, how much did meditation help the staff? And did you ever get the patients to do meditation so they could help the
Moment person used to come out of the ICU and in HDU, we used to have physiotherapists coming. We used to tell them to concentrate on breathing. We have a team of cardiopulmonary physiotherapist team and they used to come and tell them how to coordinate their breathing, how to do breathing exercises, because steam inhalation, we used to have a carton which used to contain low molecular weight heparin for 3 days, 3 days of salmeterol, 40 milligram 8th hourly dosage, and IV set, IV fluid in a one brick sort of thing. And there used to be one steam inhaler, one finger held pulse oximeter, as I said earlier, and you can say the Tagger drum to put up an IV and to fix an IV, and a sterile pair of gloves. So this is how the whole box used to be the moment patient is admitted. So this box used to be dedicatedly given, and it was barcoded and was given to the patient, and wherever the patient moves, the box used to move along with the patient. So we used to help the patient by doing this meditation by our clinical psychologist, because patient, once they starts improving, it definitely does help, and it improves the basically their mental state. They are able to sleep comfortably and able to come out of this trauma, because many a time it so happens that like we are all sitting together, the one person deteriorates, or maybe husband, wife, the wife is, there was one pastor who and with his wife had come down from Mizoram. I initially thought that his wife will pass away because she was deteriorating and requiring high level of oxygen. But over a period of time, I realized that the husband is trailing behind, and the wife, I do not know how, the husband used to look after the wife very well, go and look after the wife. And as the luck could have it, now the wife has improved, and on the contrary, the husband has deteriorated to that an extent that we had to put him on NIV support, then 100% oxygen, then on ventilator. He rather struggled for almost a month in the ICU. I never thought he will survive. His wife kept on praying and praying. She said, including her single daughter who had come from Mizoram, they were all praying, and all of their church people used to come and have mass outside our hospital for the betterment of this gentleman. But unfortunately, he passed away after a month. So definitely prayers, I always tell my patients and their attendants that once you are there in the ICU, because medicine is not it is both science and art, not only that. Besides that, spirituality and prayer do help in a big way. If you pray for the betterment of your near and dear and you give blessings, I can assure you, at least with my personal experience, it does good to the patient. And whenever I stand next to the foot end of the patient, I do pray for my patient. That is my habit. And there is a shlok in Sanskrit, Om Trambakam Yajamaye Sugandhim Pushti Vardhanam Urvaruku Bandhanam Mrityur Moksha Mamritat. So how much time I have at the bedside, I do pray once or twice and then say Namaskar.
The doctor's word.
Yeah.
That is what it is, right?
See, we are not God or goddesses. Ultimately, at the end of the day, it is the destiny. Once we feel that this person is going to die, the person survives, and the person who is going to die comes out. So we don't know. Actually, our science is still not fully evolved, and after COVID-19, we have so many ups and downs of society, of human life, and including medicine. What has made us, it is a sea change in our outlook. Of course, people's or the society has a different outlook altogether. They are short-lived, memories are short-lived, and now they are back to what they were doing in a day-to-day routine. That is real unfortunate, but we need to learn lessons. We need to be more wiser from what we have undergone this trauma.
Sure.
Thank you.
There's a question from the Zoom audience there. Go ahead.
Yes.
Dr. Bowie was asking, many conditions are accepted as having significant differences between military and non-military populations.
Yes.
Specific to military physicians and civilian physicians, are you aware of any data comparing the rates of burnout and PTSD, both pre-pandemic and during the pandemic, or data comparing the rates of suicides between those two physician populations?
Last part I could not get it.
Okay. Or data comparing the rates of suicide between those two physician populations? So military.
Non-military and military. The military physician, because almost now 5 years I am working in the private setup or the non-government setup. Earlier I was working in the army setup, which is much more streamlined. Moment you like all the paramedics and other you can say the supplies are much more streamlined as compared to what I experienced this pandemic. That is one. The second is of course the experience does matter, whether you are there in the army or military setup or a non-military setup. Basically the role model of a medico is the same whether you are there, but if you are gone through the war or ups and downs of the military, you are much more hardened to take on the load, and mentally, psychologically and physically definitely better than the other counterparts which are there in the civilian. Because in civil so far this pandemic sort of situation has not happened in the recent memories of the people, so they were not accustomed to handle these many volumes of patient. How to work together and work together as a laser beam, it requires bit of planning and then execution. You work as a good manager, how to pool in the resources. Like in our hospital, all orthopedic surgeons, the spine surgeon, including anesthetists, they were working for our ICU intensivists. So they were like parallel force which we created just with the help of our medical administration to cope up with the onslaught of so many people coming to our doorsteps.
So basically, post-pandemic, the civilian physicians were worse off than the army physicians.
Yeah, you can say to that is the main difference, because they cannot envisage to that an extent. Like in the army, I have worked both in Sri Lankan operations and in Srinagar and various other hospitals where we used to get casualties coming to us in a large number suddenly, and then you have to get mobilized suddenly. So that drill was imbibed in me. So I was able to better cope up with the, you can say, changing day to day or even minute to minute scenario. I could adapt myself, of course not mentally, but yes, both are whatever physical help and whatever are, you can say, the professional front is required, we are able to help the system in a better way, definitely.
Any other questions?
That's the only one that was texted to me. He said thanks.
Okay.
Thanks.
Thank you.
I have one.
Sure, go ahead.
What do you say to people, because I hear this around, what do you say to people that say, oh, COVID didn't really exist? Oh. No, I hear people say that.
COVID didn't?
And having gone through what you went through in the hospital, seeing all these people dying and suffering, how, I don't know if you've ever had anyone ever say that to you, but how, and if you have, how did you respond?
How do you respond to the COVID?
No, people say that it doesn't exist.
It does not exist.
See, COVID does exist. There is a definite proof that COVID is a known thing. It is not a unknown horror. So it is a known entity, and it is very well documented by virologists. Even the virus has been cultured, so there is no doubt that it is a reality. There is no doubt about it. But the quantum of damage which people thought initially, definitely with Delta virus sub variant, was much higher than what initially it was envisaged, because first wave was relatively milder. Then the second, this Delta wave really was so much onslaught was there in whole of the world that it became difficult for the people to, all the healthcare system to handle.
Okay, so it's more balancing. Okay.
Yeah.
But I would say this is a question very much common. I think.
You need to do?
Yeah. And after
Yeah.
somebody I just give up.
What's the current scenario with COVID in India?
See, sir, we currently are having various Omicron variants and sub-variants. Delta is no longer prevalent for reason unknown to us. There is no scientific reason known. But whatever Omicron variants are having, they are either having GI manifestation, gastrointestinal manifestation, or it is just confined to upper respiratory tract. So they just have sore throat, fever, no change of even quality of voice. They will have running nose, sneezing, sore throat, fever like any common cold, and diarrhea. And to our surprise, if you get the nasopharyngeal swab done, you are turned to be COVID positive. Then you tell the patient that you are COVID positive. They feel that you are unnecessarily leaving them as COVID and putting them into the isolation. That is what people think. And of course, people are not deteriorating. They are not requiring any ventilation. They do not require oxygen. Majority of the cases. There are few cases like it is very rarely that we lose a patient in past 1 year or so because of the COVID per se. That is what this scenario is.
Because of the immunity management?
No, it is. There are various factors. It is the vaccination. Sorry. Now people are aware. The awareness has come. Then do not delay coming to a healthcare facility. Come early. It is not a death sentence. So because earlier people used to come late, and now at least people come early. The awareness is there, and of course more protocols and everything is streamlined.
No, but there's a history of biology that the virus virulence keeps increasing, and finally the virus becomes less virulent and survives.
That is all. Genomics of the virus do change, and new antigen.
I guess that's it. Thank you very much. Appreciate that.
Thank you.
Professor Colonel Dr. Dutta has worked like crazy. In fact, day and night. The amount of service which he has done with the Indian Spinal Injuries Unit has been tremendous indeed. And we'd like to recommend and we'd like to give him a plaque here in appreciation of all his work with the Fraser Valley. Yeah.
Thank you. Thank you.
And I guess, sir, just hold on.
Huh?
Just hold on. I guess behind every successful person, there is a great lady there. And I would like to request Dr. Sumit Dhinnan to give this bouquet to Amita. And just can you just hold on, please? Can you just please hold on? And I guess, in fact, with our not only with the Indian community, but also with the Indian culture, but it's also with the Western culture. We do respect our parents to the last. Therefore, we would like to give this to Mr. and Mrs. Bhatt. Thank you. The lecture is over. I think the dinner will start right now.